Okay, hello friends. Mike Little here, Executive Director of the North Dakota Dental Foundation. In today's update, I just wanted to take some time to connect with all of you and to share an awesome presenter that I had the pleasure of being able to meet a few weeks ago at the North Dakota Oral Health Engagement Meeting. Dr. Timothy Ricks is an amazing individual. He has a lot of credentials behind his name: DMD, MPH, FICD. He currently serves as the 20th Chief Dental Officer of the U.S. Public Health Service, as well as Assistant Surgeon General. He serves as the Surgeon General spokesperson on oral health and interacts with chief dental officers from other countries, with military dental officers and leaders in organized dentistry, with state oral health programs, and much more. He's currently overseeing the development of the second ever Surgeon General's report on oral health. Rear Admiral Ricks has served in the U.S. Public Health Service for over 21 years. Prior to this service, he was an associate dentist, independent contractor, and sole proprietor. And he also served as a military police officer in the Army National Guard. In addition to his role as the USPHS Chief Dental Officer, he also serves in various roles in the Indian Health Services, including Continuing Dental Education Coordinator. He's responsible for 250 to 300 courses every year. Expanded Function Dental Assistant Coordinator. He oversees training and certification of 2,000 EFDAs and IHS National Oral Health Surveillance Coordinator. And finally, National Oral Health Promotion Disease Prevention Coordinator. I'm so pleased to welcome Dr. Ricks to connect with us today. And let's bring him on the screen. Dr. Ricks, hey, good to see you. How have you been?
I've been doing great, Mike. Thank you. Long time no see.
Long time no see. And I tell you what, that session on the first day with you where we were able to have you on a panel and you shared the national landscape of the data of everything that's happening in the United States with oral health, that was phenomenal. You did an excellent job. And I just was really impressed with your level of detail and knowledge around oral health. And then specifically in the breakout during the question and answer period, when you got a little bit more into this project that you had going with the IHS Early Childhood Caries Collaborative, I was really blown away. And that was during the Q&A portion, and you were able to share some information with us. And I was just like, wow, we really need to share that with our friends and see if we can't look at doing something like that in North Dakota. So we brought you on and you said yes. Thank you so much. It's great to see you.
Well, wonderful. And before I get started, let me just say it was truly a team effort that I'm going to be speaking about. So, you're giving me all the credit, but it really was the hard work of a multidisciplinary team. But do you want me to go ahead and start sharing some slides?
Absolutely. Let's do it. Let's bring your slides up. Okay. And you can have the floor.
Well, wonderful. And thanks again, Mike, to you and to the North Dakota Dental Foundation for the invitation to speak to you today. And I'm going to talk about our Indian Health Service Early Childhood Caries Collaborative. And just as a starting point, early childhood caries is defined as the presence of any decayed, missing, due to decay, or filled teeth in a child under 6 years of age. As Dr. Mike Little said, I am with the Indian Health Service Division of Oral Health, where I am the Oral Health Promotion Disease Prevention Coordinator. And so that is the context in which I'm speaking today. So for those of you unfamiliar with the Indian Health Service, we're one of the agencies within the Department of Health and Human Services. We serve over 2 million American Indians and Alaska Natives, including in North Dakota, from about 600 federally recognized tribes or nations. Our mission is to raise the physical, mental, and social and spiritual health of American Indians and Alaska Natives to the highest level. And we do this in oral health through the delivery of care in about 350 programs across 37 states. We have about 4,000 total dental staff, including 1,000 dentists, 400 or so hygienists, 2,000 assistants, and so forth. This is what we have administrative offices in 12 different locations across the U.S. I am in Nashville, Tennessee, even though my headquarters office is in Rockville, Maryland. So I do travel back and forth pre-pandemic times, not now, but North Dakota is part of the Great Plains area, and the headquarters office for your region, which includes the 4 purple states there, is in Aberdeen, South Dakota. And I told Mike this last week, but North Dakota is one of 2 states I haven't had the pleasure of visiting yet. New Hampshire is the other. And interestingly, last week I spoke to New Hampshire and to North Dakota at various meetings. So hopefully, once this pandemic is over, I'll be able to actually make it up there in person at some point.
We'd welcome you. We'd love to have you.
Thank you. So across all age groups, American Indians and Alaska Natives, AIAN, suffer disproportionately from dental disease. And you can see the 2 columns compared to the general U.S. population across age categories. American Indians and Alaska Natives have much worse tooth decay, periodontal disease, missing teeth, and so forth. With regard to early childhood caries, look at the bar graph on the right side. And what we see is that by age 2, 4 out of every 10 children already have tooth decay. And by age 1, 1 out of every 5. So when you're talking about preventing early childhood caries, which is the name of the game, right? We all want to prevent disease. 2 is truly too late. Now, the picture, the bar graph on the left shows what I was trying to say in the table, and that is American Indians, Alaska Native children under the age of 6 suffer far worse disease than any other group. 4 times as much as U.S. white children of the same age, twice as much as the next highest minority group, which is U.S. Hispanics. And before I went on, Mike told me that at Head Start age, 92% of American Indians, Alaska Natives in North Dakota have dental caries, early childhood caries, and it was, I believe, 64% of white Head Start children. So there's definitely a disparity between American Indians and Alaska Natives and U.S. whites. So I want to hone in on this 2 is too late, because years ago, pediatricians would often tell mothers, take your child into the dentist at age 2. And in fact, some pediatricians still say that. And that might work for low-risk populations, but high-risk populations, not just American Indians, Alaska Natives, but U.S. Hispanics, children living in poverty and so forth, children living in rural areas as well. These are high-risk populations, and sometimes by age 2, you're not talking about primary prevention in preventing decay in the first place. You're really talking about secondary prevention to keep them out of going to a pediatric dentist in an operating room setting. So our whole program, which I'm going to talk about, really was based on a concept of first tooth, first exam. So as soon as the tooth erupts, we encourage parents to bring their children in. So I'll give you kind of the bottom line up front. Mike already kind of talked about this, but for the first time in the history of the Indian Health Service, and we've been around since 1955, and before that, native care was carried out by the Bureau of Indian Affairs. But for the first time in our history, we've been able to demonstrate a measurable decrease in both caries experience, which means our caries prevalence, which means any history of decay, that's filled and missing teeth included, of 5%, which may not seem like a lot, but that was only over an 8-year period. And, you know, if you have any epidemiologists, trying to lower prevalence of disease is a very tough task. So we were able to do that, and we were able to lower untreated decay by 14%. Now, untreated decay is has more of a direct correlation with access to dental care. So we did have three regions as well that had some really significant reductions in caries experience. This is not untreated caries. This is the actual early childhood caries period. So the Navajo Nation, which is in the Four Corners area, had a 24% reduction. And this is noteworthy just because this is the region that has the highest prevalence of disease. The Oklahoma City area, which has the lowest prevalence of early childhood caries, actually had a huge drop at 45%. So even in good areas, we saw this huge reduction. And then in the Phoenix area, which has the second highest disease rates, we saw a 25% reduction in disease. So Mike had mentioned this about how we have this mantra of it takes a village, and it really does. So remember back to I said first tooth, first exam, and the question is, how many of you see 6 months of 6-month-olds in your dental practice? And the answer is probably very few of you. And like I said, pediatricians were often referring children, telling parents to take their children to the dentist at age 2. So very early on, we knew, because 2 is too late, that the key to success was getting children under the age of 2 into the dental office or reaching out to them, one or the other. So we did this by, making sure that everyone understood that early childhood caries is not a dental problem. And in truth, if you look at the research, it really isn't. Early childhood caries has a number of effects on children, from missed school days later once they start school, to low self-esteem. And if you don't believe me, go to any Head Start and look at the child that has all their anteriors with stainless steel crowns and how the other children react to that child. So low self-esteem. There's even studies from the Maternal Child Oral Health Bureau of where early childhood caries sort of sets this path to where children have lower success even after the teeth are restored, lower success in school, and less success even as adults. So early childhood caries really starts a cascade of negative events for children. So back to the question, who sees 6-month-olds, 9-month-olds, and so forth if the dentist doesn't? Well, that's what we aimed to find out when we started this. And so we reached out to medical staff, public health nurses, because we know children are getting vaccinated, right? So there's the well child clinics and things like that. The Women, Infants, and Children's program, of course, they, especially with American Indians, Alaska Natives, many are tuned into that. So that was another resource. Communities and tribes often run by, elders, kind of run the tribe. So we want to influence tribal elders so they could spread the word, because word of mouth is really effective. Obviously, Head Start and Early Head Start were important partners, daycares as well. And then in the Indian Health Service, we have a special paraprofessional called a community health representative. They're usually Native American from that tribe or community, and they go into homes and do health assessments, blood pressure, glucose, and so forth. So it was only a natural fit for them to go into homes and talk about oral health education. But it's beyond just talking. We actually trained Head Start teachers and daycare teachers, medical staff, public health nurses, community health representatives, how to do oral health assessments and how to apply fluoride varnish. And so the picture on the top left is actually a physician doing an oral health assessment. And for those of you saying that's not a big deal, you should see physicians doing oral health assessments. It's quite different. So, but we're very thankful that they're, the American Academy of Pediatrics now has a very robust oral health assessment guide and so forth. So you can go there to learn more. On the right, the picture is a circle brush at a Head Start program. And so they all, sit at the table, and there's an adult teacher or an aide that shows them how to brush their teeth. And of course, that was pre-pandemic stuff. And then down the bottom left is we actually wanted to create a superhero. So we had a Native American adolescent design Mighty Mouth. And Mighty Mouth, and you can barely make him out. I probably should have put a better picture. But he's the dude with the green tights and the yellow cape in the back. And he's holding a composite gun. One for glass ionomer. So because we were trying to promote glass ionomer sealants and interim therapeutic restorations using scoop and fill and glass ionomers. So many of our programs, and I believe that is actually in Pine Ridge, South Dakota, where this picture was taken. But they had, used Mighty Mouth as the prop, and they had, pictures of Mighty Mouth, and they'd handed out, cavity-free kids, all that kind of stuff when they went out and did community fairs. So again, we had pretty significant results nationally. And on the right is what I really want to talk about. So we had 4 goals. One was to increase access to care, especially in 1 to 2 year olds, our children under 2. And what we saw over an 8-year period was a 22% increase. And remember, these are dental practices that have, just like your practice, that have competing priorities. You have lots and lots of disease. You're trying to treat, you're trying to complete treatment plans, all of these things. And what we encouraged programs to do is to have something called open access. And it's really quite simple. Children, young children that are at high risk shouldn't have to compete with adults to get an appointment slot. So how long does it take to do a quick oral health assessment on a 6-month-old with 2 mandibular incisors? It takes about 10 seconds, right? How long does it take to apply fluoride varnish to the same child with two teeth? And the answer is none, because you can get your dental assistant to do that. And it takes the dental assistant about 10 seconds. So you don't need to you don't even need to put a child in a chair to do a quick oral health assessment screening and educate the parent. In fact, what we often had was the mothers would hold the child, and you would just put them under the dental light so you could see and do a quick check. And it didn't even have to be done in a dental office. We did this in early Head Start. We went to daycares. We did community health fairs and so forth. And it was not just dentists. It is not rocket science to see big black holes in teeth. So we actually developed a lot of packets, brochures and stuff for different partners, like physicians, like community health representatives, Head Start, and so forth. And I'll tell you, if you want to learn about all of our different materials that are available, you can go to ihs.gov/DOH, that stands for Division of Oral Health, /ECC, Early Childhood Caries. And on that site, you'll see things like a caries stabilization course, because we not only promoted access for children, but also their mothers and fathers as well. And we want to stabilize, take care of their dental caries too, to prevent that transmission of bacteria from parent to child or caregiver to child. A second thing that, back to access, we had a 22% increase. The amazing thing is, of that 22%, 14% were referrals from outside the health system. And that's, just think about that. That's not medical providers sending children to the dentist. This is Head Start and daycares and all these people that we taught to do oral health assessments, basically lifting the lip and seeing if there were dark spots. So that was a significant improvement. The next thing we tried to do was to encourage our providers to apply dental sealants. And you say, well, everyone does dental sealants, right? Try a dental sealant on a 1-year-old. Okay, it's not easy. And one of the things, so in 2016, the American Dental Association and the American Academy of Pediatric Dentistry came out with a policy statement on glass ionomer dental sealants on primary molars. That was 2016. This initiative that I'm talking about started in 2009, and we advocated that 7 years prior to the ADA and AAPD. So there was a huge paradigm shift from oral health professionals, dentists, hygienists, and assistants doing resin sealants to moving to glass ionomer sealants, especially when moisture control couldn't be achieved. So they're very, very young. And because of that, we had a 48% increase in dental sealants. Our next goal was to increase fluoride varnish. And if you go on like the Association of State and Territorial Dental Directors website or various other websites, you'll learn that the standard is 3 to 4 times a year of applying fluoride varnish to high-risk groups. That standard actually came from the Indian Health Service. So we encouraged 4 times a year. But, in truth, we had so many people applying fluoride, physicians, public health nurses, Head Start, daycares, and then in our dental clinics and at health fairs, that some of these children probably had 10 or 12 applications a year. There is no harm to topical. There's never been shown any harm to topical fluoride. So too much is not a problem. Too little is a problem. So we encouraged everyone to administer fluoride varnish. And again, it only takes a few seconds. If you watch fluoride varnish videos, they show this, how you gently swab the teeth with cotton and how you can get a little paintbrush and you paint really soft and just make sure it's on the enamel and so forth. You don't have that kind of time when you're dealing with a 6-month-old baby that opens his or her mouth for about 10 seconds. So what I used to do, and still do because I participate in Give Kids a Smile Day every year, is I would put the fluoride varnish on my 2 fingers and go along the teeth, 1 finger on the facial, 1 on the lingual, and again, sometimes it's only 2 teeth, so it's even easier, and apply the fluoride that way. You only have a few seconds to do. But we actually, as the result of this initiative, we had a 115% increase in fluoride varnish applications, 335% increase among non-dental providers. And you say, well, none of them were doing it before, and that's not exactly true. Physicians, the American Academy of Pediatric Dentistry, American Academy of Family Physicians have taught fluoride varnish application by medical professionals for quite some time. So the fact that we had such a huge increase was really more because of the nurses, not the physicians. And we had a 227% increase in 1 and 2-year-olds. Now, why is that significant? Because I came from private practice before I went into the Indian Health Service. And when I saw in private practice a mom bring a 1-year-old or a 2-year-old in, I got the referral notebook out and start writing the referral. But we actually had a huge paradigm shift. The number of referrals that we had were decreased significantly. And it was because dentists got more comfortable with that 30-second encounter with the 1-year-old. And so they could paint the fluoride varnish. So we had a huge increase. And then finally, interim therapeutic restorations. There was a paradigm shift in this as well. In dental school, all of us are taught remove all decay. And, always apply or administer anesthesia if you think it's going to be deep. Well, with ITRs, the entire concept is to not traumatize the child. So there's an existing cavitate lesion. You scoop it out with a spoon or a large round burr, and if you get close to the pulp, you leave the decay. And it is not malpractice. This is an interim therapeutic restoration. There have been many studies, GI, glass ionomer releases fluoride. So it is a very evidence-based thing. And what we learned is most of the time, even though this is called interim and it's treated like a temporary, if you have a good marginal seal on the glass ionomer, it ends up being a permanent restoration because the tooth exfoliates before you have to replace it. One interesting thing that we saw is even after our initiative was over, that those benefits of establishing a dental home, getting in to the dentist regularly, getting fluoride varnish 3 to 4 times a year, getting all your teeth sealed that if you're at high risk, and most Native American children are, actually, we saw the results further on down the road in 6 to 9 year olds. And so you can look, our last major survey on 6 to 9 year olds was in 1999. And then we did it again in 2016, 17. And what you'll see is pretty much dental caries experience in all teeth and primary teeth and permanent teeth and untreated decay in primary and permanent all decreased pretty significantly in 6 to 9 year olds. And we attribute this to the Early Childhood Caries Collaborative. So the question is, can this be replicated? And what are the keys to success? So the first thing I want to mention is first tooth, first exam, because again, 2 is too late. 1 is too late. 1 out of every 5 Native American children already has decay at age 1. Collaborative partners are important because dental can't do this without reaching the very young children. And you have to have people that promote that idea. You have to have people that do referrals to dental. One interesting thing is we saw through this initiative, I mentioned tribes and communities and talked about elders, but in fact, what we saw was some tribes passed tribal resolutions in support of ECC prevention, and then they were like our megaphone. They amplified that message throughout their tribe. Another one, I mentioned WIC earlier, Women, Infants, and Children's Program. We had one area down in Mississippi, one tribe, that would not extend WIC benefits to mother and child unless the child had proof of a dental exam. So that was a major policy change that affected change. Again, I talked about the multiple paradigm shifts in general dentists. And the picture on the right, I just thought was, I would put that in there. Do I refer this young child to a pediatric dentist, or doing exams, fluoride varnish, sealant, and ITR, usually in 5 to 10 minutes at most? And we had many of them go to that blue side as a result of this. Then, I mentioned the GI sealants. We were 7 years ahead of our time on promoting glass ionomer sealants. And I think as you see more and more research, it's not just the fluoride release from GIs, but if you do a good GI, the retention is very, very similar to resin. And even if it falls out, you're buying time, and you can do a sealant, resin sealant later on. What we often told our providers is to do nothing on a high-risk kid is almost malpractice because you're just waiting for the teeth to bomb out. And then, again, ITRs, even if caries is left behind. The key to atraumatic restorative techniques is the atraumatic part. So, if you traumatize a child, they're going to be, they'll remember that for the rest of their lives. And all of us as oral health professionals deal with very apprehensive, anxious adults that had bad childhood experiences. So that is it. You can email me if you have questions, tim.ricks@ihs.gov. That's the best way to reach me. There's my phone number as well. And so with that, Mike, I'm going to stop sharing and take some questions.
Yeah, sounds great. Well, thank you, Dr. Ricks. Excellent job. That deeper dive really, you did a great job. It was good to see the specifics of what you were able to share in just a few minutes at our engagement meeting a few weeks ago. I do have a couple of questions here. I guess first off, when you talked about what you were expecting initially, and then with those initial goals and objectives that you had laid out, and then the actual results that you ended up getting, were there any surprises to you? Anything that came out of those results or in the process too, that really surprised you?
That's a good question. I would say I think the biggest surprise was that across our country, in Native American communities, the champion for early childhood caries prevention wasn't always an oral health professional. We had nurses that carried the banner. We had and they would get their dental teams involved. We had these community health representatives who were from the community, had a vested interest in the community, and sometimes they would be the leaders that were going over to the dental clinic saying, "Look, please make room for this kid in your schedule," and things like that. So I'd say that the leadership of the many collaborators was the biggest surprise of all.
And I'm curious, so as you built It Takes a Village and you showed the slide with all of the partners, was there a way that you formalized this partnership, or how did people become ambassadors of the program? How did they sort of internalize it to take this on and champion it forward?
So, I mentioned our website. We had training courses that we put on for, our collaborative partners, national webinars and things like that. But we also had these packets, and we could count how many of them downloaded the packets. We had not only a caries stabilization course, which was more aimed at oral health professionals, but we had a how to apply fluoride varnish course as well. And many of the non-dental people took that course. It wasn't a requirement, but I would say we had probably close to 1,000 people taking that course. So I think it was all of these things combined was the way we tracked how many people were involved. But the numbers kind of speak for themselves as far as the non-dental contributions with access and fluoride and so forth.
Yeah, for sure. That's good to know. And I love I think you guys are going to have to franchise Mighty Mouth. I like that idea of wearing a mascot costume. That's great. What were some of the challenges that you guys experienced? So as you were rolling this out and then this multi-year project, it sounded like, you mentioned just the fact that you were sort of ahead of the curve on a few of these things, right? Like some of the recommendations that came out later on glass iometer sealants. And so could you just walk us through what were some of those challenges for you?
Yeah, and I'll first say with Mighty Mouth, we couldn't find anyone to actually don the costume. So, Mighty Mouth's just on paper. And so, but I'd say the biggest challenge probably was just relying on technology. Okay, so when you're trying to get word out to 350 dental practices in 37 states, how do you do that? Well, our carrot was we had continuing education webinars so they could get credit. But at least in our practices, the key is not the dentist, but it's the dental assistant, because most of the dental assistants are from those communities. So getting the word out to dental assistants proved to be the biggest challenge. And of course we did, used emails and webinars and things, but I cannot tell you that we had 350 programs participating. We had some programs that there was just absolutely no change. So I think if we had to do this again, we would have done more in-person visits. And I did travel around the country, and we have regional managers as well that traveled out to the sites, but we didn't get to every site. And this is one of those initiatives where you can't just present it one time and hope everybody buys it hook, line, and sinker. You have, especially the paradigm shifts that I've been talking about, you really have to kind of hammer it home over and over and over to talk about, the effectiveness of GI sealants, getting other people involved, doing oral health assessments. So I think the biggest challenge was just technology itself and getting the word out.
Mm. Yeah, and that kind of ties into my next question a little bit, just about what it helps ensure that this multidisciplinary collaborative approach succeeds. So when we think about bringing diverse groups together like WIC and Head Start and these different groups, it sounds like that in-person connection is really key. It sounds like multiple touch points, being able to just be consistent on message is important, and just developing those relationships.
Yeah, and as Chief Dental Officer of the Public Health Service, I'd go around the country and I speak to, or pre-COVID now, just virtually go around the country and talk to state oral health coalitions. And the ones that are successful have a lot of non-dental partners. They bring in non-traditional groups, Families USA, Head Start, parent-teacher organizations, and so forth. And I think that's kind of what I mean by it takes a village, is that you've got to think outside the box and bring non-dental people to the table, because they'll not just help amplify the message. In some cases, like daycares, Head Start, they'll actually be the referral source. So I think that's the challenge as all of us move forward.
You mentioned that idea of when you're connecting with these different groups that are maybe not initially a part of the oral health community, but in these other areas, any recommendations for how to overcome the potential barrier of it's not my problem? Or, that's one of the typical barriers you can run into is people not maybe seeing the connection. And so any recommendations on how to bridge that barrier?
Well, two recommendations. Number one, I made a very distinct point that early childhood caries is not a dental problem. And you have to make that sell. And there is a lot of research that shows the effect of ECC on, childhood obesity, on, psychologically, self-esteem, success in school. So all these external partners, surely they're interested in one of those things. So if you can tie it into something of interest to them, that is a key to. And the other thing is, I wouldn't bite off more than I can chew. I wouldn't bring in all of the dental stuff. I'd focus on, say, early childhood caries or school-aged children, something like that. Make it a small thing. The second recommendation that I would have is, for those of you that are oral health professionals, is adopt a bi-directional approach at integration of medical and dental care. So all of you that are oral health professionals are health professionals. So think about the things that you can offer back to your medical colleagues, blood pressure screenings, diabetic screenings, depression screenings for behavioral health, and all of that. So that might be the other way to overcome the barrier. Say, if you do this for me, then I'll do this for you. Developing individual, everything in an initiative really depends on the individual connections. So, reaching out, and, if you still have to have a mask on, whatever, but reaching out to potential partners in person or phone calls is much more effective than doing emails and things like that.
Yes. Well, good, great recommendations. Amazing results to see the significant changes that you guys were able to see over this time period within this patient population, and way to have courage and step out and try something innovative and take a new approach and connect with partners to make that happen. As we wrap up, I would like to offer you any additional comments or thoughts or things you'd like to share with our audience today or North Dakotans that are watching?
Certainly. I mean, I'll just say again, like I said in the very beginning, this wasn't a Tim Ricks thing. This was a true team effort by many oral health professionals and collaborative partners across almost 600 tribes or nations in the country, including those in North Dakota. And we're really, really appreciative of all the work that everyone did. And it's not like it's over. It continues. We've now institutionalized all of these different things that were novel ideas back in 2009. I also want to call out my boss in the Indian Health Service, Dr. Tim Lozon, who supported this program throughout its entirety, and my co-chair, Dr. Bonnie Brewer, who is now retired, but she was in Oregon, and she helped create this along with me. So, and again, I want to thank you, Mike, and the North Dakota Dental Foundation for the opportunity to speak. And if anyone has follow-up questions, feel free to contact me.
Thank you, Dr. Ricks. Thank you for what you're doing to improve oral health for all. And thank you for joining us today. We appreciate your time.
Thank you, Mike.